Hey everybody, Ethan here. Today I'm going to talk about secondary hyperparathyroidism and chronic kidney disease. Honestly, though, this topic got me thinking about Black Friday, and rather than get involved in the occasional brawl this year, I decided to go online. But before really shopping, I thought to myself, if I'm going to buy something, I've got to be more selective. Many of these deals aren't really deals. So I asked myself, Ethan, what are you missing in your life? Answer to that is, adequate discipline, a mature sense of humor. There's many things. But I would say chief among those things, perhaps, is fitness. When you look up sedentary in the dictionary, you see a picture of me sitting in this very chair. So I said, you know what would be good? A kettlebell. That's how I'm going to get in better shape. So I started looking. And it's here that I think some wisdom from Dr. William Osler is very apropos. Osler said, the value of experience is not in seeing much, but in seeing wisely. But what if you don't see much and also you don't see wisely? What if you see the cheapest kettlebell available on Amazon and just bought it? Well, that's what I did, failing to read the dimensions of the kettlebell or the fact that it was basically made of concrete covered in plastic, or the fact that reviews I found that the plastic could crack and the concrete or sand on the inside could leak. All I cared about was look like a kettlebell. It was 25 pounds. I can't lift that more than that. And that was it. All right. And when the kettlebell came, I was shocked by its size. All right. This thing was easily bigger than my head. And remember, I have a big freaking head. You need space, right, to store all the nonsense that I spout. And further, as you can see here by my hand, the handle is thick. And it's made, as we talked about before, of plastic. It's slippery. And given that, I want to do kettlebell exercises like, I don't know, these kettlebell swings that you might see here, the risk is that I swing the slippery thing, it flies out of my hands, and I've got some serious property damage or injury on my hands. So, because I'm stubborn and it's a pain in the rear to return this thing, I made a little grip here out of some paper. Is it a perfect solution? Absolutely not. Am I an idiot? Of course. But the lesson here is simple. One, don't do stupid stuff like me. Buy kettlebells without reading about them. But also, two, realize that there's always a secondary cost. That idea of secondary costs and downstream effects is the broad theme of today's video. The kidney is important. We need kidney function to survive, period. And when it's diseased, as you see here, there are a lot of things that we think about as problems, right? Poor kidney function will dial up the RAS system. It's going to create fluid overload, cause hypertension. The kidneys are key for filtering blood. If you don't filter, you get the buildup of urea and other toxins. But another important downstream effect of all of this is the effect on calcium, and as a result, the parathyroid. And today we're going to talk about three things. One, how does the kidney regulate calcium and phosphorus, particularly phosphate? Two, how does the parathyroid regulate calcium and phosphorus? I'll just say phosphate. And three, how does chronic kidney disease lead to secondary hyperparathyroidism? So let's start with how the kidney regulates calcium and phosphate. As always, this will be an oversimplification, focused primarily on the links of secondary hyperparathyroidism, but let's just get started. We got to first talk about phosphate. The kidneys are very important in regulating phosphate homeostasis, and generally, the kidneys reabsorb around 80% of filtered phosphate. However, when phosphate is low, the kidneys can reabsorb nearly all of it. Generally, though, due to high phosphate intake in normal diets, which nowadays is about, as this study shows, about twice the recommended daily allowance, the goal of the kidneys generally is to decrease phosphate, excrete phosphate, in order to maintain stable serum levels. If we're taking in a lot of phosphate, we got to make sure we're getting rid of it, right? If we want to maintain the same levels in the blood. So clotho, seen here, clotho is a key cofactor for the action of FGF23, which is shown by this like sort of royal blue T-shaped thing. Together, they stimulate urinary phosphate excretion, seen here by the action of these two, inhibiting the uptake of phosphate and sodium from the lumen. By inhibiting uptake, by inhibiting reabsorption, you keep more phosphate in the lumen, and therefore more is excreted. That's the kidney and phosphate really in a nutshell, all right? Let's talk about calcium, where the kidney's main job relates to vitamin D. Vitamin D3, which can be obtained via exposure to sunlight or through food, gets a hydroxyl group added in the liver, right here. Boom, liver added, boom, 25 hydroxylates. Now you have 25 OH vitamin D3. That creates, again, that 25 vitamin D3. But to create truly active vitamin D, well, that activity happens in the kidney because the kidney has this key enzyme here, 1-alpha hydroxylase, which adds another hydroxyl group to create 1,25-hydroxy or dihydroxy vitamin D, or hydroxy dihydroxy. I think it's dihydroxy vitamin D. Apologies, I messed that up. This activated vitamin D, also known as calcitriol, is critical for calcium, but also phosphorus homeostasis because this calcitriol, or activated vitamin D, enhances the intestinal absorption of dietary calcium and phosphate from food. Remember, just because you eat something doesn't mean you actually absorbs the nutrients from it, right? Activated vitamin D, which again, I'm just going to call calcitriol from now on, increases the intestinal absorption of calcium and phosphate. This is foreshadowing, but the diagram here shows a key link between the two concepts we just discussed. FGF23, which we just discussed as a key mediator in increasing phosphate excretion, also, see this minus blue arrow here, inhibits the action of 1-alpha hydroxylase and in turn decreases the amount of calcitriol that is produced by the kidney. This makes sense if we think about it, because what is the goal of FGF23? Well, it's to increase phosphate excretion and lower serum phosphate. If activated vitamin D, if calcitriol increases intestinal absorption of phosphate, that's going to work at cross purposes. It's going to work against the action of FGF23. So it makes sense that if FGF23 is high, we're trying to decrease serum phosphate by excreting to the kidneys. We also want to decrease the amount of vitamin D because we don't want to pull in more phosphate from the intestines. So, in short, calcitriol, which is activated vitamin D, increases serum phosphate by increasing intestinal absorption. So it makes sense that when FGF23 is high, we'd want to turn down calcitriol production. So now, let me just sort of review what we talked about. 1, FGF23 decreases renal phosphate reabsorption, increasing excretion, right? We're dropping phosphate. 2, calcitriol synthesized in the kidney, increases intestinal absorption of calcium and phosphate, increasing, right? Serum calcium and phosphate. And lastly, FGF23 inhibits the action of 1-alpha hydroxylase, which decreases the levels of calcitriol, which then, as a result, secondary effect, decreases the serum calcium and phosphate. So let's move on and talk about parathyroid hormone, right? Parathyroid hormone plays a critical role in calcium and phosphate regulation. I want to start, though, with a little acronym that my professors taught me, which is to think of PTH as phosphate trashing hormone. In short, one of the goals of PTH is to as the name implies, drop the phosphate, but it also serves to increase serum calcium. This diagram is a bit complicated, but it covers everything they really want to cover. Simulated, right, by low calcium seen here, high phosphate, and is also inhibited by high vitamin D, PTH does a number of things. It first acts on the kidney to increase calcium reabsorption, decrease phosphate reabsorption, and increase the activity of 1-alpha hydroxylase to create more calcitriol, right? Increased calcitriol does what we see here on the left, and we've talked about it, right? It's going to increase the absorption of calcium and phosphate from the foods you eat. Sorry. There's also a direct effect of PTH on these bone osteoclasts, right? So see this PTH arrow, boom, to osteoclasts. What do osteoclasts do? Osteoclasts break down bone. They resorb bone, and by breaking down or absorb bone, you liberate the calcium from bone. Again, the goal is now increasing calcium levels. Now that we're talking about bone, I want to talk now again about FGF23, which you see here. FGF23 is what we talked about, a key mediator of decreasing phosphate reabsorption in the kidney and decreasing activation of vitamin D to calcitriol, also in the kidney. FGF23 critically is made in the osteocytes in bone and is triggered by high serum phosphate. Additionally, one other thing I want to talk about is that emerging research argues that PTH directly stimulates FGF23 expression, which if we think from a purely goal-directed perspective, that really does make sense. Because if the goal of PTH, phosphate trashing hormone, as I said, is to drop phosphate, then dialing up FGF23 is going to help excrete more phosphate. So that makes sense, but that connection isn't as clear as this ones you see in this figure, but something I just wanted to mention. The keys, though, I do want to remember about PTH are, 1, in the kidney, it increases calcium absorption, decreases phosphate absorption, and increases activation of vitamin D to calcitriol. In the intestines, the increased calcitriol from the increased activity of that 1-alpha hydroxylase leads to increased absorption of calcium and phosphate. And in the bone, PTH works to increase bone resorption to increase serum calcium. Again, what's the goal of PTH? Increase the calcium, decrease the phosphate trashing hormone. So with all this background established, I now want to talk about the pathophysiology of secondary hyperparathyroidism, specifically precipitated by kidney disease. Chronic kidney failure, right, which is what I just said is a trigger for this, is a terrible disease. It's clinically diagnosed by a reduction in glomerular filtration rate, but the pathogenesis stems from the creation of like a pro-inflammatory microenvironment that is caused by hypertension, diabetes, ischemia, or other causes like toxins that creates oxidative stress and endothelial dysfunction. And remember, that's a big problem. Endothelial dysfunction and oxidative stress is a big problem because the glomeruli and renal tubules are very, very delicate. And that damage that you can see here on histology is very obvious, right? You have sclerosing of vessels, you have fibrosis of the interstitium, you have sclerosing, glomerulosclerosis of the glomeruli. And this damage has very key functional implications in the pathogenesis of what we're now going to talk about, secondary hyperparathyroidism. There is some disagreement on the first shoes to drop in this disease process, but it really doesn't matter in the grand scheme, I think, because they're all interconnected. One key initiating factor is the kidney's inability to excrete phosphate in the setting of kidney failure, right? Renal tubular damage leads to a failure to filter and excrete phosphate. And that leads, of course, to serum phosphate. If you can't excrete it because you're not filtering, right, you're going to have higher phosphate in the blood. Higher phosphate in the blood does what? It increases FGF23 levels, which is, makes sense. You're trying to excrete the phosphate, but that exacerbates what is known as the potential other first shoe to drop, which is really decreased 1-alpha hydroxylase activity, right? The kidney's damaged, you have reduced GFR, that 1-alpha hydroxylase is not going to work as well. And that enzyme, remember, I told you before, it's in the kidney. And the fact that this enzyme is not working as much leads to low calcitriol. And the low calcitriol inhibits intestinal uptake of both calcium and phosphate. So what does that mean? So your calcium's going down, your phosphate is also going to have a sort of negative pressure. But again, that negative pressure on phosphate is going to be pretty much outweighed by the fact that you can't even excrete it. The key, though, critically, is that both these changes, the low 1-alpha hydroxylase in a low calcitriol and the high serum phosphate, lead to the same thing. They trigger increased PTH. Because going back, right, to this diagram, in the setting the kidney's in now, the parathyroid is being activated by a lot of things, right? We've talked about how kidney failure causes hyperphosphatemia, high phosphate, because the kidney can't excrete it. So that's going to stimulate the parathyroid to make PTH. You have low activated vitamin D. So low activated vitamin D means you can't absorb much calcium from the food. Low calcium stimulates PTH. And you have low vitamin D, as I just said, or low active vitamin D, I should say, because I just mentioned you can't make the calcitriol, and that's going to help stimulate more activity of PTH. So all of these things is going to stimulate the PTH. It's like an all-system-go environment, and that increased PTH is going to do a couple of things. First, we mentioned about it before, it's going to stimulate the activity of osteoclasts, right? It's going to try to increase bone resorption to support serum calcium levels and elevate them. It's also going to pull or push on the kidneys to try to reabsorb more calcium and secrete more phosphate. But one of my favorite expressions, pushing on the kidney in this kind of situation is like pushing on a string. It's going to get you nowhere because the kidney is failing, right? This bad boy is in big trouble. So this complicated pathogenesis helps explain the lab values you most typically see in patients with secondary hyperparathyroidism. You first are going to think about seeing high phosphate because the kidney can't secrete it. You're going to see low calcitriol because the kidney can't activate vitamin D, and it's further suppressed by high FGF23, right, because of the high phosphate. So you have two things that are going to make it very hard for 1-alpha hydroxylase to work. You're going to see low calcium because the kidney can't reabsorb it, and the intestines can't either, or can't absorb it, I should say, because there's low calcitriol. You're also going to see high PTH because all of these factors above continue to stimulate the parathyroid gland, and you're also going to see low bone mineral density because the high PTH is going to stimulate significant bone resorption, significant bone breakdown to try to support and elevate those serum calcium levels. So that's secondary hyperparathyroidism. It's secondary because the hyperparathyroidism isn't an inherent defect in the parathyroid, as we've covered. It's secondary to another process, in this case, kidney failure. So with that in mind, what did we discuss today? We talked about how the kidney excretes phosphate, especially under the action of FGF23, and activates vitamin D to calcitriol, which increases intestinal absorption of phosphate and calcium. PTH decreases serum phosphate and increases serum calcium by affecting bone resorption, kidney reabsorption, and activation of vitamin D. And lastly, kidney failure impedes calcium reabsorption phosphate excretion, and vitamin D activation, leading to hypocalcemia, hyperphosphatemia, low calcitriol, and high PTH. I hope this was at least somewhat helpful, useful, perhaps entertaining. Here are my sources, references. I wish you all the best. Take care. Have a good one. Bye-bye.